So I'd like to introduce our first speaker then. Our first speaker is Dr. Paul Dempsey, mathematical scientist at Dassault. He has a background in mathematical physics and theoretical astrophysics, and now applies his experience in mathematical and computational techniques to a wide variety of real-world problems, including COVID-19 control in Ireland. So you're very welcome, Paul, and please go ahead.
Okay, so for the first part of the talk, we're just going to talk about data and how we come to it, and a little bit about modeling and why we need modeling rather than just depending on what comes out of the everyday news. So here's the recent LEA maps that come from the CSO and the HSBC joined and published on GeoHive. But one thing we also remember is if we're trying to look at this map and think, well, how risky is my area? It doesn't really represent what's going on right now in your area. So generally, it takes around 5 days from infection to symptoms, another 6 days from symptoms to a case. Then when we're using the 14-day average, which continually gets reported, that means you have to take away another 6.5 days to try and get back to what it might have been like then. So that leaves you in the daily figures when they come out and they mention the 14-day daily average or cumulative, a risk profile from what was about 18 days ago. Now, when you have the LEA maps for your local areas, that's adding another 6 days of delay again. So you're really looking at the risk profile from the best part of a month ago. So when we're obsessing about data, we have to remember it's generally historical and quite historical when we're looking at things. So that's why it's very important to have models on top of your data to kind of get a projection for what things are like now. So what kind of things can models do? Well, if you get up a model, you can, and Philipp will talk about this later, how to actually set them up and how they can project into the future, but they can also explain what went on in the past. So simple models for say, if it's the same model was applied in China at the very beginning, applied to New Zealand when they made their decisions, could kind of project that if we go hard, lock down hard, we'll be clear of this by May. When Wuhan reopened, timed its Wuhan, it also kind of suggests that the no active infections about 2 days before they reopened. So they really timed it very well. Modeling can also be useful when things fall over. So in Ireland, we kind of delayed quite a long time before doing anything. We really delayed in the lockdown, but we also we ran out of tests beforehand, so we restrict our testing practice. What modeling can do is it can fill in the gap to get a feeling of what was going on in the past. So this type of modeling then would have predicted that during round one, we would have had around 100,000 infections in the country, and that's close enough to what the serological studies have suggested as well. One of the things that keeps coming up, why can't we copy Germany? Why can't we copy Sweden? Why can't we copy whoever we want to copy? Now, the problem is for every country has some sort of different elements going on. One of the most important things we've heard over and over again from in ethic briefings is the in-house transmission. And one of the kind of key things that happens here is adults are the drivers. When you look at individual houses across Europe, there's a big difference in how many people live alone. If you live alone, it's much less likely that you're going to be able to pass on that virus to somebody else. In fact, even for when they did kind of studies in lockdown in Israel and in New York, and they looked at adult-to-adult transmission, it was in and around 40% chance of being passed on to somebody who you're living with. It's much less, again, on individual contact with your other close contacts. But if you have enough of close contacts, then you get into a situation where it gets out of control. You get this R value greater than 1. So that's kind of the data as is for Europe. And how does that manage up to what's going on with our R zeros? Well, it gives certain countries a distinct advantage or disadvantage as a starting point in how they're going to approach this. So the idea of every country trying to do the same thing would be disastrous in the EU for the countries above that orange line, and would be fine for and possibly overkill for some of the countries on the other end, the other side of the screen. Now, the other question that keeps coming up is where are the deaths, where are the hospitalizations compared to, say, the first part? So what's different from now and May, June? Well, in May, June, all of the age groups, except the under 15s who aren't particularly affected. We're all pretty much on top of each other. So they all when you were seeing all the age groups, all the cases were pretty distributed according to how the population would expect them to be. So there was only maybe a 2-day lag between the over 65 getting it and the younger people. Now, when we move on to this period of time, we have the over 65s. The level they are is probably around 2 months back from 1 month back, 4 weeks back from where the youngest cohort are, and a month back from the general population. So there's, as well as the previous lag we had in the first phase from deaths from cases to deaths, we now have on top of that another lag from this uneven distribution. Now this is something that you might think, well, that's good, except it's not sustainable. We've already, for two reasons. One is the data and one is in theory. In the data we've seen in France, the same thing happened. And I'm just going to use this pointer here, hopefully you'll see it. Their over 90s got hit very badly in the beginning, disproportionately. Then in the summer, it went good for them. But then when the numbers in general started to rise in France, the over 90s tended back to equilibrium. So in where they should be if the thing was the same over the whole population. So you're going to now expect France, and as you see here, the young people started to go back down as well. And likewise with the older age groups here, they're slowly getting closer and closer to matching the general population, which is something that just means we can't do the shielding. So that's fine. What about in theory, which is always kind of second to what really happens? But even in theory, it's not going to happen. So if we set up a group of invincibles who never get sick, but it just treated as the common cold, and they maintain immunity for the 4 months that's projected, after which they can pass it back on again, and they get all infected nice and quickly. But the vulnerable community, who was restricted to one contact with another vulnerable member of the community and one with an invincible who has to care for them or has to do anything, then it doesn't really, you still have a very large chunk of that vulnerable population getting the virus, getting infected. And if reinfection kicks in, which hopefully it should be around next January, or January 21 when it starts to, we see that it will just keep going and going and going as the population, and then eventually you'll have the same amount of infection in both cohorts. It's also, like, forgetting about the maths of it, it's also pretty cruel, the idea of shielding. If you look at what's going on in Ireland, the over 80s, the ones who are getting infected, are only meeting 2 people as close contacts. Now that's over a 3-day period. That's not in any way a equitable or a good lifestyle for them to be having. So it's something that we really want to try and break down. As I showed earlier here, the lag here, the 1 month lag, is also closing. The growth rate in the older age groups is higher than the growth rate in the younger groups. So they're getting closer, and that's just because the whole population drags as one, even if a certain part of the population is trying its best to shield itself. Now, do lockdowns actually work? Well, we've seen before in Ireland, but not just Ireland. We saw pretty much the exact same effect in Northern Ireland, the Republic, and Scotland, where they implemented good attempts to control and stay at home and keep that kind of going on. Whereas in England and Wales, they didn't quite go as hard, and it left them at a higher base level. But once we opened up, and always going to happen if you open up when you're still community transmission as a possibility, or when you leave your airports open and your borders without quarantine facilities, the cases just shoot back up at a rate that is proportional to the amount of activity that's going on. Now, do they always work? Well, if they're well maintained. Here we have Ireland in our earliest lockdown, versus Victoria in their recent one to try and get control of the situation in Melbourne. Ireland and Australia, or in Melbourne, had the exact same rate of decline for the vast majority. Australia had a slightly better one, but they have a quarantine facility, so they don't have to worry about extra new cases coming in, even when the numbers are low. When did it start to go wrong for Ireland? Well, there's lots of talk of schools and all of other things. The real issue happened, and it wasn't a phase 1, so it was really somewhere in the middle here, when people started just meet a little bit more than Ireland's population that allowed it to happen. So this is when it showed up in the data. It was back just before phase 3, and then that correlates to 11 days beforehand when the environment really changed. So when you're doing these things, analysis, you always have to take into account the changes that you project happen between the cases and your data. So okay, that's kind of when it started to go wrong. When it really started to go wrong was the Kildare outbreak. And if any questions from that later, you can show that maybe the containment zone for the Kildare outbreak didn't really match what it needed to by forcing ourselves to think of things in counties rather than where people travel. The good thing from the Kildare outbreak, you can actually see there was a dip later that lower than you would have expected from just close contact. That kind of could be only really explained by an effect of the lockdown in the community. Now, this idea that we're trying to live with the virus has to be kind of considered, well, we're seeing it right now, we're considering level 4, level 5. When we looked at level 1, which is pretty similar to what we had just before around the time that schools closed, we were looking at daily changes of between 20 and 30% day-on-day increases. In level 2, we've observed this recently, so we've seen it go in Dublin before they went to level 3, and in the rest of the country as soon as the pubs reopened. We see around an 8% day-on-day increase. The hope for level 3 in Dublin, and it did look like this in the early times of level 3, was that you get something like a 2% day-on-day decrease. Level 4 we won't know about, and level 5 gives around a 6.5% day-on-day decrease. That's what was observed in Ireland in our first attempt, and also again in Melbourne and Scotland, and pretty much everywhere that doesn't involve some additional testing or other techniques to bring it down faster. So how do we, if we want to live with the virus, so if we want to keep it at a steady non-zero value, how do we achieve that? Well, if we spent 7 days at level 1, then we need to spend 77 days at level 3 or 23 days at level 5 to give a balance. And that's again being hopeful that level 3 works. Level 2, again, so where we were 7 days on level 2 means 27 days on level 3 to give itself a balance, or 8 days on level 5. So you have to bounce around and around between 2 levels. This idea of bouncing around levels was suggested by some Israeli mathematicians way back in May, when they were, or maybe before then, when they were trying to open their society without having to worry about to give some economics value to it, but without having to worry about the virus continually overwhelming its system. They didn't listen to those math people at all, and you can see what happened in Israel. Level 3, if it's not working well, it's 7 days on that. And if it is working well, maybe you get the swings and roundabout balance, which there was some suggestions might be happening in Dublin until the most recent figures. To clear that, you'd still need 2 days of level 5. Now, so these are kind of environments, and these kind of daily changes only really count when it's wild in the community. If you've got other interventions, but they can always help and stop that, and they could, just like we saw in Kildare and Offaly, where they kind of knew exactly where the outbreak was, and they were able to wipe it up very quickly. But the environment in general really depends on where you start. So in whichever scenario you start, if suppose you start with 5, you still end up, or 50, you still end up after the end of a month with 87. That might seem okay, but it really does depend on where you're starting, where your starting point is. It's much easier to start with 0 when you don't have to worry about, well, will people will they get fatigued? Will they slip? Will they start being normal again? No matter what level of normality you have, as long as you're somewhat cautious in what you're allowing into the countries or into your region, once you keep it at 0, no matter what the daily increase of that environment is, it can't go anywhere. It's a multiplier. Now, why does it matter if we try and live with the virus? What the other issues that come along is, it depends what this level that you're happy with living it is. If that level corresponds to a new admissions of 5 per day into the ICU, then very quickly the ICU becomes overwhelmed. Likewise, if we look at our hospital admissions and they hit 40 a day, then they're going to get overwhelmed as well, and we're going to have to cut back on our normal services for hospitals and ICUs, which is already happening even at these levels, because this is assuming that we're stagnation, and we're not stagnation. So going back to what was introduced to everyone at the very beginning was the curve, and another reason to be concerned with living with the virus. The curve with lifetime immunity is kind of fine, goes away. So many people will die, and that used to make then people make a judgment call on what's acceptable, and that happens. But once you have reinfection, which is known from the 80s, is expected to be somewhere around 45 weeks for going back to a full reset. But you only get this constant level of infectious people in your population. And once you have that, you just have to be living under restrictions to continually push this down. Now, this is nothing to do with opening and reopening. This is simply staying the same and just looking where we're going to end up in a kind of endemic situation. The other issue with worrying about this is when we try and come around and look at a vaccine, we have to make sure that it's both effective enough and has enough uptake so that it gets the coverage required, so that the vaccine herd immunity threshold is met. So somewhere around our normal living situation, which was somewhere between 3 and 5 is what most of the data is suggesting the R0, the initial reproductive value requires quite a high combination of both uptake and multiplied by the efficiency to try and see how much we really need to cover our population. It seems like we're going to need an extremely good vaccine to get back to a normal life. And that said, a vaccine will make things like elimination easier if we were to continue with things like social distancing and maintaining all of the good behaviors that we're trying to suppress our normality. So one of the other things I suppose I come across with trying for a natural herd immunity, which the reinfection rules out anyway, but even if it was lifetime, where our herd thresholds for a population level could be somewhere around here, but it will always, that's where when it starts to slow the virus down, it still has a long way to go to get through the rest of the population. So how do we get around this? Well, the best way, as well as lockdowns aren't something we want to do for long, that when they're required, when they're required, and they're definitely required right now in Ireland. But if we have an aggressive testing for people who are most at risk, so things like hospital workers, direct provision, factory workers, different types of testing regimes can really suppress the virus. Some you might want to have very aggressive testing every 3 days in something like a hospital or healthcare nursing home, so that it never gets into the location in the first place. You might be able to get away with something a bit more like 7 or 14 days in your factories, because you can then get your public health teams to do all the hard work of cleaning up and making sure it doesn't spread. Beyond that, again, only an issue when you're living with the virus, trying to live with the virus. So how do we kind of get around this and be realistic as well? So pushing it down to 0, we know how to do it, but it's a question of how do we leave it at 0? So one of the ways to do it without really impacting too much on our workforce and making sure we minimize the amount of damage to how people interact is to look at how we do interact. And the CSO have all this data, so do the mobile phone networks anonymously. We can tell where people are moving and where we need to set up zones of control. So you kind of see down here in Cork and Kerry, they have their own little zone, Limerick, Clare and bits of Tipperary, Kilkenny. The Dublin region is quite broad, obviously, but up where people are most given the biggest excuses for not trying this is up in the border region. But we see that actually the cross-border region, there will be no point for the virus actually putting anything on the border itself. It's much more important to put it, say, here between Dundalk and Drogheda, and in areas where you can let people live the lives that they need to live without impacting on any kind of politics. It's literally, we would have a region of control here, a region of control around here, regions of control around here, where you can allow people within those zones live normally without impacting on anything else. And this is something that Australia had to do when they were setting up their quarantining borders. It didn't follow their administrative borders at all. So between New South Wales and Victoria, they actually they didn't just take the administrative border. They actually said, well, where do people live? Where do they move? And they matched their quarantining around those practical areas rather than concerning themselves with any of the politics of the issue. So if we do go into lockdown, now they've waited a long time to make a decision. It's made it the chance of having a relatively safe Christmas for, say, visiting grandparents quite unlikely even at this stage. But if they were to announce a level 5 later today, there is a realistic chance that they could get cases back towards the August values, forgetting about any ideas of zero COVID by then or anything like that, because they've left without investments in testing and other techniques to try and isolate the cases. That by Christmas now, that boat is gone. They need to be doing this a while ago if they wanted to have a safe Christmas. So in Cork and Kerry or in Dublin regions, and again, something similar for all the other regions, you can kind of project where something relatively predictable like level 5 would land us. And that's all from me, and I'm going to pass over to Philipp now.
Thank you very much indeed, Paul, for that fantastic delve into the numbers. It's given us a lot to think about. I think you'll find that Philipp's talk is going to be very complimentary, so we'll take questions at the end. Please do put your questions into the chat. This is very thought-provoking. Go ahead, Philipp.
Okay, now you should be able to hear me. Can you hear me, Helen?
Yeah.
All right, so the button moved from the bottom of the screen to the top, so I found it again. All right, so yes, so my name is Philipp Hoevel, and I'm an applied mathematician, which means by definition I should be good with numbers. But even myself, I find myself struggling with some of the numbers that I'm facing and putting them in perspective. So
can I interrupt you, Philipp? I forgot to introduce you. Isn't that a terrible thing?
If you want to do so,
I will introduce you right now and say that Philipp Hoevel is a lecturer in applied mathematics at University College Cork, and he's a mathematician and physicist who researches complex systems and control theory. He applies this to neuroscience and epidemiology and other areas, and has been funded by the Health Research Board to conduct research estimating the burden of symptomatic COVID-19 disease in the community here in Ireland and the public health impact of that. So back to you, Philipp. Sorry not to give you your introduction.
No worries, Ellen, no worries. So I already shared that I'm an applied mathematician. And I try to make sense out of the numbers, and I try to walk you through some of the thoughts that occurred to me over the last couple of weeks and months, and then take you to a specific study discussing possible scenarios for the future and things that may work or may not work for various reasons. So moving on here, this is the latest number, the latest data that we have from this GeoHive art, and it always starts with these headline figures, the confirmed cases, total death, latest daily cases, and so on and so forth, even down to the positive rate. So I'd like to give you some ideas of what you can infer just with back of the envelope calculations from here. So looking at the total number of confirmed cases, for example, it just happens to be short of 50,000. So if you just take that number and just take a look at where it all started back in early March or very late in February. So you take that number of 49-something thousand confirmed cases. It took us about 7 months to get to that number. Well, now if you say that the population of the Republic of Ireland is around 4.9 million, or around 5 million, just take the fraction of those two, you see it's almost exactly a 1%. We say if that took us 7 months to reach that many people, to get that many people infected or confirmed cases, then if you want to aim for, say, 50 times that many, because we heard something about herd immunity already, 50 times that many, that long, this will be on the order of decades. Or now you can say this is just the confirmed cases. So give it some, like an under-reporting factor. Let's say the real numbers are 10 times as high. Still, you would be ending up talking about years and not weeks or months. And so it's still going to be a very long time until anything like herd immunity would even be coming up on the horizon. So this is clearly not a viable option. Another thing that you can take a look at, a second look if you like, this is the numbers then plotted here over time, starting from last day of February all the way to today. Blue is the confirmed cases, and red is the confirmed death, and here's even the aggregated version. Well, here in the aggregated version, you can kind of see this already, this exponential growth for the first peak, and down here for the second peak. And I'd like to speak a little bit more about those numbers here. So if you take them, and you can download them freely available from the website, I plot them here, now in pale blue. If I do a little bit of a different display, so I'm going to use the exact same data, but I'm just going to switch the y-axis here to this logarithmic scale, which means between any of those lines is a factor of 10. So we have seen similar plots from Paul already. So we do that, then it goes from 1 to 10, from 10 to 100, and from 100 to 1000. So we are just above 1000 in the latest numbers here. You can see that you have better resolution of the lower numbers that way. And what is striking to me, if you just take a look at the first peak, the tip of that peak, and this looks really like a straight line on here. And the same if you go to the bottom here, to the valley, and you take a straight line on here, it's almost spot on. So I just did it without any fitting, just purely doing the numbers, start taking this number, and then I decreased by 6% per day. So this is not a fit to the data, it's just 6% per day, starting from here. It's really following that line all the way to July. Similarly, if you start on 1st of July with the number that I was reported there, and I take a 5% increase, so it's again very much spot on. So this really shows that it hasn't been an exponential decay, all right, but it's also an exponential increase. And this has been going on not for the last couple of days, but this has been going on already since July. So we knew in July that something was amiss. So the numbers were low, but still kept increasing. Well, the exponential curve otherwise is quite a beautiful and curve with unique properties. So the values today is a fixed fraction of the values is going to be the increase tomorrow. So in this case, 5% increase today means that 5% of the numbers today will be added to the numbers that we have. And then tomorrow, on top of the numbers added, there will be another 5% of that already increased number. So whatever you do to model this with, say, a polynomial, say, a quadratic equation where it doubles every 7 days or so, the exponential inevitably will go ahead of it. So this will increase and will explode sooner or later. So in July, we were in the shallow waters of the exponential, but finally the curve went on, and then the numbers became larger and larger, and now we are in the 4 digits. 4 digits here, latest daily cases reported just for yesterday. This number doesn't mean much if you don't put it into perspective of the available pool of susceptibles, or available pool of people that can potentially catch the disease. And we have seen that the confirmed cases was around 1% of the population. So how much is this then? So it's much, much smaller. But if you put this in perspective to the European landscape, and here this is the data that's been updated daily by the ECDC, that's the European Center for Disease Control and Prevention. That's also the basis on which the Irish government decides to put countries on the green list or off the green list. So right now there's not a single country on it, but this will be the number that they're going to consider, which is the 14-day cumulative number of COVID cases per 100,000. So here it's ranked according to the sum of cases. You can see that the countries with large population, so they are quite naturally on top. But if you re-rank this according to that figure, that's what I did here. I put Ireland down in red. So the data the day before yesterday, where we were around 211. So the condition to join the green list of countries, the list of green countries, that's 25. So even by our own standards, we are way above. And in fact, there's not a single European country at the moment that would qualify for that. And you can see that some countries that have been recently in the news, like Czechia, which has been quite seen a very rapid increase. I think it was yesterday more than 11,000 new cases. So we are among good company, but the numbers are rising all over the place. So it's really time to start doing something more serious restrictions on that. So if we are not in the 11th hour, I would say we are close to the to minute, and here the bell's ringing already. So it's if it's not even too late, we need to take some quite dramatic actions. And for that, I think the simulations and modeling efforts, they can really help to project into the future and to test various strategies and see where this might take us. So in other words, simulations look into the future, in particular nowadays. And this is a perfect period for modelers, because if any of the models that you come up with, they are only as good as the data that can verify them. Data has become more and more available, and authorities more and more willing to share those data. So data-driven models, they pop up all over the place. It's also good that depending how you set up the model, you can really write down the clear assumptions. So you can test within the limitations of the model what the scenarios look like. So the models, they're reproducible. So it's not witchcraft. So if you put down the equations, anybody could put them in the computer and try to reproduce the numbers. They're flexible. If there's something coming up, let's say you go from a roadmap to a level system or to a traffic light system, or to introduce any other measure, you can take a look at this beforehand and see and engage the impact. And they're adaptable. So even if completely new game, a new player comes enters the game. So let's say there's a vaccine available. So would this affect the numbers? So all of this can be included into the model, and they can then point you towards the future. So I will take you in the next couple of slides to a model that we put up. So we, meaning that's people at University College Cork, together with PhD students and fellow colleagues. And we posted this already in June. So we made prediction in June about the numbers later this year and even beyond that. And what we found is this. So in blue is the data again. So that's in this case the confirmed death, because this seems to be the most reliable, most rapidly reported number. So the number of infected, there's a lot of underreporting going on, but we felt that the reported death, that this is really an estimate where you can gauge our model against. And what our model says, that's the orange curve. Right? So it started in spring or early spring, and then went up, has some slope, and now the slope is even increasing on here. But on top, I think we agree that the model that we set up and the data, they match quite well. So how does this look like in detail? So this is quite a crowded plot, but I take you through this step by step. So first of all, we have time down here, and the number of individuals in different categories. So blue, for example, would be infected in the model, infectious. The number of death, this would be red. And the number of healthy is this purple line, where we start at for an all Ireland model. So this includes both the population in the Republic of Ireland and Northern Ireland. This would be this purple line. So if we start at almost zero, then we have the first peak around where we went into first lockdown and the stay-at-home order. So then in the model, we can switch the parameters, accounting for the roadmap, so the phases 1 through 5. So we see that was this trough, so this minimum down here in July. And since then it was, even though we were still in phases 4 and 5, the numbers are rising already. So right now we are around October, November. So here the number of deaths has still plateaued. So it's even in this logarithmic scale, where between those two lines, for example, it's an increase by 10 from 1,000 to 10,000. You will see that the numbers, if you don't do anything, if you don't have any other measure, no containment policy whatsoever, the number of deaths will keep rising up until you reach on the long run. And this is where herd immunity will take us more than 100,000, and I don't think that this is a scenario that we would like to explore and see realized here. So let's see what on top of this, if you call it doomsday scenario, on top of that worst case scenario, what can we do to kind of tip this curve around? And that's one of the possible scenarios, and that's the nice thing about the modeling. You can put in any containment measure that you like to see tested, and see how things work out. For example, you can say that the healthcare system could cope with, say, 10 to the 4th, so it's 10,000 people infected at the same time. That's for sake of arguments. You can put any other number and say if that happens, you go back to phase 1, so lockdown, and then you release it after a period of 3 weeks to phase 2, 3 weeks, phase 4, 5, and so on. If you do that, then you can get similar to the first peak that has been diminished afterwards. There was this decrease here. You get the same decrease over here. You get a minimum, and then once you're out of phase 5, it's going to start again. You will hit the threshold again, and the whole story continues. And so you get this kind of almost periodic curves, which are roughly 4 months apart. So that's also not a scenario that will take us anywhere close to herd immunity, because if you see for the red line, you see these little increases step by step. Every time there's a peak, this will stay still below 10,000. So just for sake of argument, we try to extrapolate this, and it's again on the order of decades. So that's also not really an option. So we can put it under repeated lockdown. So how this looks like on a map, just put it here. That's data from the Central Statistics Office and NISRA, that's equivalent in Northern Ireland. So we just see the first peak, and now it's summertime. Everything seems to be small, low numbers and quiet, but we'll see as we get to more recent times that the numbers will come up again. You see it starting in the big cities, but really spreads all over the country. It doesn't really care about borders, about county borders, about border between Northern Ireland and the Republic of Ireland. If you keep going to the new year, you'll see that there's another peak coming. So you see those repeated phases of waves coming in, and you would have the same debate as we have now. You would have it just in 4 months down the line, and then another 4 months. So there'll be a couple of more of those severe outbreaks carrying it over to the next year. So that's not an option. If you compare those peaks, they even look quite similar. So this was the first peak around the middle of April. Now I've changed the color code so to get better contrast. So the bright color is really where the hotspots are. You compare this to, say, the rise where we are heading for at the moment. And if you, in the simulations, aiming for a lockdown just before you reintroduce the next lockdown, you see also flares all over the place. If you compare this again to the next 2 peaks, you'll see the picture is just repeating. So it's the same story times and times again. I don't think that this is really a viable option to have this discussion, this debate, and repeatedly every 4 months. There's another thing that you can test. You can test, say, a county-based restriction, as they are being talking at here at the moment. And again, nice thing about the model, you can put in any measure that you can dream of. For example, here, just for sake of argument, we said in any county, we can have 200 infected tolerated, and then we'll put in again complete lockdown and have the relaxation similar to what we had in the phases 1 through 5. So if you do that, the highest curve, so one curve is one aggregated value for the counties. So Dublin would be the highest curve because it's most people that live there. So you see that this peaks earliest, and then it's going to go down. But all the other counties that will follow sooner or later. So there will be again this repeated series of outbreaks. Maybe the peak is a little bit off by a bit delayed by a couple of days or weeks, but it will happen. And this is only if you assume 100% travel restriction. So it's really that people stay within their county and they don't move anywhere else. Now, we don't know that this is not true. There's essential travel, which is allowed. There's also non-compliance. So if you say that, well, just take a look at that, 20% of the normal amount of travel, that's okay, either it's tolerated or there's non-compliant behavior. See that Dublin goes up, and then there's the introduction of the lockdown. So it goes down, but because there is this residue of travel, it doesn't go down to zero, it even increases further. And so that's just for 200 cases, so it's not going to get down. The peaks will be quite high still, and that's for 200 infected in the county. Is this a realistic scenario? Let's see. You can put this also on the map and then see how the different counties flare up. So this is the first peak in March, April, and then we entered the summer. Everything was quiet, and even area around Dublin cools down. And then coming up to July, October, September, and October, you can see that the numbers build up, pressure builds up on the system, and you have outbreaks all over the place. This would be now, and then you can also see what happens, say around Christmas period, at least in this simulation. If you keep this county-based restrictions going, it will not go away. It will still be there. Just going back, introducing those restrictions will not help us, and it just there's too much residue in the system and too much leakage if you just have some essential travel allowed and non-compliant people. Right. So if that's roughly today, this is what the scenario would look like around Christmas. I think this is clearly also an enjoyable look into the future. I said this is for 200 cases in the county. That's not exactly what we had. So when Dublin went from level 2 to level 3, they had around 1,300 infected in the county. So that's where the order of curves turned around. And again, assuming 100% efficiency of travel reductions, this would get the things down. The number of infected will go down, but will come up again. Now, if you think of, again, having non-compliant people or allowing essential travel, you can see that by gauging to the first peak that we had in March, April, even if you introduce those regional, county-based restrictions, see the numbers rising higher compared to what we had in March, April. And even on later times, this peak will be repeating. Plus, there will be flares at almost arbitrary times in any of the other counties. Also not a too enjoyable option. All right, Paul mentioned something which is also known as hammer and dance scenario. So this would be something, a plannable scenario, 2 weeks of lockdown, 4 weeks of free behavior, let's say increased levels of awareness comparable to level 3. You can also try how this looks like, and you get those like shorter oscillations, but you will still get a number of infected, you can contain it around 1,000, but still the number of deaths by 5. So any of the things that you can, if you can test them in the model, but overall, what we are faced with here is at the moment, and what we see, it's really more a strategy of firefighting and not strategic long-term solutions. So what I presented were non-pharmaceutical interventions. I'm not talking about any vaccines because it's you need to speculate when the vaccines might be ready. If you have anything like non-pharmaceutical interventions, and you don't do this in a very coordinated fashion where you ramp up testing and other accompanying measures, then you are in for a couple of another waves until any of the vaccines might even become available. I'd like to finish with some comments on things that I observed recently, which is either lack of communication or non-reliable communication, because we need to have a clear set of actions. Otherwise, the community and society will not buy in. Plus, there needs to be something like a silver lining or motivating outlook. And that's where this ISAG, this Independent Scientific Advocacy Group, comes in, because there's quite a whole mix of measures proposed. So it's not this single one measure that will do the trick. We need to really have a concentrated effort on all of them. So just to pick one, zoning. So we have seen from Paul that maybe the administrative reasons are not the best to define zones. But once you have a zone cleaned, for example, you can just check the mobility from mobile phone data, for example. Once you have a zone cleaned, people could move freely in that zone. And as the zones become larger and larger, so if the neighboring zone is free of COVID, so it's really an elimination process, then those two get connected. You can increase your radius of interaction. This goes hand in hand with the find, test, trace, isolate, and support strategy. And all of this needs to be really clearly communicated. Let me finish by comparing also other countries, and I just picked 4 of them here, which have either which underwent quite a severe lockdown, like Israel at the moment. You can see that it does have an effect. So the numbers go down, but you need to have societal buy-in. People need to comply with rules. Otherwise, sooner or later, even if you get the numbers down, they will go up again. I also put Japan and South Korea more as an examples for compliance. But here the numbers are on around 600, but that's also a country of under 20 million. So compared relative to Ireland, these are low numbers, and the healthcare system could cope with this. Even contact tracing could work on that. And finally, we have New Zealand down here, where the numbers reported here, confirmed cases, are again around a dozen, which is low enough that public health could chase after them, one after the other. All right. So in terms of communication, so I was an umpire for quite some time, and we always use the KISS principle. And there's various versions of it. You can say keep it simple, stupid, or keep it stupid, simple, or keep it short and simple. In any case, if you roll out some strategy, you need to communicate it very well, and the people need to remember what it is and be able to act on it. So a simple set of rules, similar to some other famous person of Irish descent said, you should not ask what your country can do for you, but maybe the other way around as well. So don't wait for orders, take a proactive step if you feel that something is amiss. So it depends on every single one of us and the society to make a clear statement, change the behaviors quite a lot. So the final thoughts on this is, and communication is key, it needs to be clear and timely and decisive. The working at the university, the decision not to open face-to-face teaching, I think was the right one. Doing this the working day before the semester started was much too late. Damage was done at that time already. Now it's hard to contain it. This is one example. Finally, having the outside perspective from somebody who has been in the German system for quite some time. Ireland is an island after all. So while there's demand for a European solution, this country is different from other countries in the sense that the number of countries with which we share a land border is very low. So it's different from, say, France or Germany, or any continental countries on continental Europe. And finally, I think it's important to say that we need to have an increased or like revised common sense to change our attitudes and behaviors. For example, just putting some questions here. Do I really need to go to certain places? Do I need to visit somebody? Can I reduce my contacts to X%? So we have seen that this very much helps to prevent the spread, also by the slides by Paul. If you think of how many households can we meet, this doesn't mean that if we have a party and then every hour there could be another friend coming in, and then we can touch and pat ourselves on the back and say, oh, we comply with the rules. No, we don't. So if you think that, what would be your, say, 1, 2, or 3 fixed number of contacts that you can still meet? This would be make life much easier for contact tracing, and would slow down the spread of the virus and break the transmission chain, or at least channel the transmission chain quite an extent. And finally, if you go out, wear a mask. So these very simple solutions that could contribute to the greater good. So after all, where do we go from here? It's the latest figures for Ireland. Where do we go from here? I don't know. It's going to increase because there's this lack of reporting, at least for the next 7 days, the numbers will go up. And then it's really for us to come up with a strategy from a long-term solution. And anything for repeated lockdowns, I don't think it's viable. It's not good for the economy. It's really stressful and nerve-wracking for the people. So we need to come up with a different solution. And I think those green zone strategies, difficult as they are to implement and how expensive they might be to implement, I think this is, at least from my perspective, one of the only way that we could go forward to live also an enjoyable 2021. All right, so I think I stop here, and then Hannah, I leave it to you to channel some questions in our direction.
Thank you very much, Philipp. Thank you very much for taking us through a very complex subject with great clarity. I'm sure you'll all agree that the 2 presentations were very complementary, so it puts us in a great position to be thinking very sobering to know that where we are now was predicted back in June and was totally predictable, and we really have to bring that predictability back in and get ahead of the virus. But very empowering as well, because the more we understand these data, the more we can really take control of the situation. So I'm going to pick out the questions. We've had a great set of questions here that have been sent in by the audience. Orla Hegarty would like to know a number of things, among other things. Would like to know about the environmental factors, including spring headwind, autumn tailwind, and what is known about building, ventilation, and transmission. So what are the climatic, seasonal, environmental factors involved in transmission?
Most of the models, well, network models anyway, but reading them, just they will derive the transmission from the data. So it will be live updated as they go along. Yes, there may or may not be climate or seasonal factors, and we won't know that. Since May to July, the parameters that would have been derived then, and the contact numbers since then are consistent with it just being spread by, sorry, not just by, primarily being spread by close contacts. But we've seen just community contacts is a big chunk as well. So all contacts are still the same. Yeah, the difference between different kind of contacts only really comes into it when you have low numbers. Once you've got a large number, the average is a reasonable way to predict what's going on. It's when you get down to the low numbers that it matters whether you've got super spreaders, because then I suppose super spreaders aren't the worst thing, because it means you know where they are and you can track them. We saw that in South Korea with their nightclub incidents, that they were able to put out all the stops and track down every single contact with that event. And the average OR number used is, the OR number is an average. It does take into account the highs and lows. Again, it's mainly valid when you've got a high number of cases. When you've got a low number of cases, modeling is more suggestive than predictive. You've got to just trust your people on the ground at that stage.
Thanks, Prof. Philipp, will you like to add to that, particularly with regard to the environmental factors, first of all?
Yes, so I mean, the virus started in early spring, and then over the summer we can say roughly more or less similar climate behavior by the people spending more and more time outdoors. I think it's without much thinking, I think it's fair to say that if you move indoors, there's a higher risk of transmitting if people gather. So there's the reports and studies about aerosol content that linger in indoors much longer than outdoors. So if you go for a walk, that's safer than just going on a running track indoors, for example. There was also the question about ventilation. Ventilation might also be one of those things where it's not just the single unique measure and to prevent the spreading, but it certainly contributes to reducing the chances of catching it. So if you have to have a meeting, wear a mask, open the windows, good for try to keep good ventilation running. So it's just one of the things, one of the little bricks that will help us to achieve the goal. And the thing about the seasonal effect is that we enter now the colder days, and influenza and any flu is just waiting around the corner with quite similar symptoms. And I think it's also without much imagination, we can be sure that if the immune system has been weakened by a virus, say influenza, it will find it harder to fight other viruses. So I think the seasonal effect will have indirect effects when COVID-19 breakouts, so coronavirus and other viruses come together, and we simply don't have the data to predict what is going to happen. But if anything, I think it will make it worse.
Yeah.
Following on just from that single point, one thing was noticeable over the summer, and especially in China early on, was when people self-isolated, it really slowed down with any symptoms. It really slowed down the spread. If we don't continue to self-isolate, as soon as any kind of symptoms show up, it really risks it going. You could see up to 50% increase in the R number, and by not self-isolating.
So, I mean, that takes us back to the need for support as well, of course, for people to self-isolate, so we can be absolutely sure that they'll self-isolate.
Yeah.
Okay, so the next question was from Liam Fanning, wanting to know about in the older age groups, the 50s, 60s, 70s, 80s, etc., about the earlier time of death. So a bit around, I suppose, the whether the deaths are being brought forward and what effect that has on the models. Philipp, I think maybe.
Yeah, I can say a few words about that, and then Paul, you can also come in and reporting on this latent effect on the high age groups at the moment. Yeah, this goes back to the question: oh, can we shield the vulnerable old population? Right. So even if we succeed doing it, quite some ethical controversy here, but even if you succeed doing, they are still the rest of the population at risk. And I think even a father or mother of a young child is also quite at risk, and there's been cases where Corona strikes also with the younger population. So those predicting that those predictions do not affect only the vulnerable, will also have an impact on the younger populations. And so therefore, any type of shielding will not work. Plus, we have to come up with a strategy which supports the elderly, and I think the most supportive part would be that we can have the virus eliminated from regions where we can then behave freely again.
Do you want to add to that, Paul?
Yeah, just for a kind of example there for the 50s, 60s, 70s, 80s. So if you're 45, if you make it to 45 and you're a man, you can expect to live another 34 years. If you make it to 55, you expect another 25 years. If you make it to 65, you can expect another 18 years. If you make it to 75, you could expect another 11 years. And if you make it to 85, you typically can have another 6 years on average ahead of you. So it's not a case of, oh, the median age of death is 83. Sure, that's a good life. No, once you make it to those ages, you can reasonably expect to go well beyond them.
Yeah. And another comment on this is there's the people immediately at risk because either their immune system is weakened already, and they would face either severe symptoms leading to eventual death. But there's also the studies about long COVID. So even if you have a mild symptomatic case of COVID, there could be quite severe impacts on your health on the lung system. So it could affect any of the inner organs or have any other detrimental effect on the long run. So it's not only the immediate number of deaths, but it's also a long-term effect, and this also apply across all age groups.
Okay, thanks. Next question from Dermot Dorgan. Could you say something about the estimates of the true number of people in Ireland who've been infected from surveys?
Well, based on modelling, I got around 100,000 for round one, and I haven't updated the numbers for round two yet, because they're definitely testing more. So they've definitely caught an awful lot more than they caught in round one. They're probably not, up until a few weeks ago, there was probably catching the vast majority of cases between contact tracing and everything else.
Yeah, I think that's a good observation, Paul. If I just go maybe just to my second slide here, there was also this positivity rate on here of so the number of positive tests, the percentage of positive tests. This has also been going up over the last couple of years, so last couple of weeks. So it has been in like 1 point something over the summer, which means there were 400 people tested, only one was positive. And now, so my epidemiology friends tell me if that rate goes above 10, you're not testing enough. Yeah, there's too many people that slip the system. So if that number is also be interesting to be watched. So if this goes higher up, then we're also reaching the resolution of the testing capacities. So to catch really most of them.
Yeah. Okay, so we'll move on to another question from Anne Foster. Is NPHET's fatalism rooted in them still thinking in terms of influenza rather than SARS? Any comments on that?
No idea.
Yeah, I'm not entirely sure what you mean by NPHET's fatalism. I mean, from my perspective, I've been talking to modelers in Ireland and other countries. It's not so much dependent on how the details of the model look like. Almost all models say the same thing, which is kind of reassuring and frightening at the same time. So we put in what we did, a system that is based on like, differential equations on the network. You can put in an agent-based system, some probabilistic stochastic model. At the end, it doesn't really matter. If the mechanism is put in, they all show the same symptoms and also the same results in here.
I think the question maybe is referring to fatalism in terms of living with the virus as a term as opposed to elimination of the virus. We're in a very different situation without a vaccine, etc.
Yeah, well, for influenza, there is we are in the lucky position, fortunate position that there's a vaccine every year coming out, so this helps protect the society. So a completely different system, different type of virus. With the coronavirus, we are still learning. It's not even clear how the immunity or waning immunity, how long this will last. So we don't really have a clear answer on the fatalism. I don't like the notion of living with the virus. I would really like to live without the virus, and having living in a zone that has been eliminated and from the virus. So I think this is a better perspective than trying to do any measure that just contains it but doesn't get to the root of the outbreak, because then we'll see the outbreaks just reoccurring a couple of months down the line.
Yeah, elimination as a better way to go. Okay, so Ronan Smith is asking, if the government announced level 4, level 5 restrictions later today, how long would it take before the daily cases could drop to single digits?
Yeah, Paul, I can take this.
Yeah,
I just go.
I'm still looking at my details here.
Yeah, I just go to say, if so. Last time, the first peak that was in the end of April, and then it went down. So single digits would be anything below this 10 to the power 1, below 10. So if that's a measure, first estimate, then it took us about 2 months to get to single digits. In general, you can say getting from a reduction, so from 1,000 to 100 takes the same as going from 100 to 10 takes the same as from 10 to 1. So it's getting harder and harder to really squeeze out the virus at the tail of the curve. But I think the duration will be weeks and not days.
So the second part of that question is, and then how long do you project after that the country could have a stable no cases per day? In other words, elimination, from single digits to elimination.
Well, the issue is about a testing regime and making sure that you turn off the tap. You have to turn off the tap first. You have to risk assess the tap, make sure there's quarantining in place at the airport and all ports. Risk, if Belfast decides only to test, then you can risk assess what the chances of the virus getting through and having testing facilities set up in certain regions that are most likely to infect it, so you can actually keep it low, keep it under control. You're talking about really changing how you approach it. Like Melbourne approached pretty much the same way we approached the first lockdown, which was just, well, let's just keep everyone inside and it will go down on itself. And that's what happened. And it's relatively predictable. People maybe had 1 or 2 outside visits a day, and that pattern followed. If you intervened with things like more regular testing of healthcare staff, factory workers, retail workers, you can get those cases to go down faster than the exponential decline, but it requires effort.
Yeah, I like this question a lot. How long do you project after that the country could have stable no new cases a day? This really much depends how we prepare for the next, say, trough, the next low number period. So if we manage to get our head and decision aligned so that we have good protective and preventive measures for any re-imports or any spreading, to reduce any community spreading once there is another outbreak, then this could hopefully last as long as it needs to be for a vaccine to arrive. So, but this needs to be really a serious change of policy, so that we make use of the time while we are firefighting the current outbreak, that we really go to clever and intelligent long-term solutions that are also sustainable. So the answer is, I hope with the right measures that it will last for months, and not only for a few weeks to 2 months.
Yeah, well, single cases aren't an issue. Like I said, you just put the systems in place to catch them. Like we have single issues of TB on a regular basis. We've got loads of this that comes in. We just are able to manage them. We have the systems in place. I know from when Ebola was an issue way back, that the hospital systems were perfectly set up to deal and manage what they were expecting then. But again, on this, at the end, if we get down to low numbers, so at some point we have to plan in making sure our healthcare workers have a breather of some form so that they don't get totally and utterly burnt out by this up and down, if the government decide not to head towards a minimal COVID, stable minimal COVID approach.
Yeah. Yeah, we have a lot to do now, but in a sense, this is the moment to do it while the restrictions are on, to prepare for the next phase and make sure we're not in a cycling situation. A few questions around schools to, I think, probably end with. I'll take one question after that. The evidence about transmission in schools, whether there's a difference between primary and secondary schools, whether they need to close in order to have a zero COVID policy, and whether they could do a different type of testing strategy. Paul, would you like to take that first? Any comments around the schools issue?
Well, primary school is very, very different than secondary school. There's the younger cohort, under 15-year-olds, are much less likely to transmit and much less likely to acquire, and it's a compounding effect. It's seen in every country. It's not zero, but it is. If this was purely about children, this virus would die out on its own. This is an adults-driven scenario. Even the cases I know school-wise related here in my locality, it's the teachers meeting. It's been teacher spread inside the school. I haven't heard of any child-to-child transmission yet inside the school, in primary schools, but the secondary schools where you effectively got adults. I mean, but these they're masked fully. It's a high risk. There's so many other issues around that schools, as well as just the kids in it. There's a meeting up around it as well. The testing and screening, it's the same for schools as it is for everywhere else. If we were willing to take a chance that maybe 5% of our kids had to be held out every day because they have a positive on a test that's not perfect, and then they get a proper test, testing could really allow for schools to stay open even as we head towards zero COVID. But it's risky. Yeah.
Philipp, do you want to add to that around the school?
Yeah, I fully understand this is a very important question that affect the day-to-day business and daily lives. But I'd like to point out that opening or closing schools has a lot of secondary effects, positive as well as negative effects. So it's not only the act of being on the compound of a school, it's also the way to the school, it's the way from the school, it's also the chance of socially mingling when the kids are at school. So there's a lot of things. It's not this only one measure. Yeah, we need to close the school and everything's going to be fine. So it's need to be accompanied with other measures as well. And once we are at a zero COVID strategy and the numbers are low, then if one lives in a green zone, then schools can open and act quite as normal. So even without any restrictions within that green zone. But it's also clear that if there's a re-import and the outbreak happens, there needs to be clear protocols what will happen. So people should not be caught by surprise about the measures taken then. And that's what I mean by clear communication is missing, and We see it all over the place, not only primary, secondary schools, we see it up to the third level institutions and universities, that students are getting very worried and staff doesn't know how to act and react on this. So it's more than just saying, facing the decision, we close the schools or we open them. So there's a lot of secondary and indirect effects connected to that decision.
Yeah. Yeah. Okay, well, I know there are a lot more questions in the chat, but I'm afraid we've more than run out of time. So what you can do is email them to the address on the website, ISAG, because we will have another town hall next week, next Monday, and these questions I'm sure can be addressed also next Monday. So I would encourage you to come back. I'd like to thank the speakers for their highly informative and interesting discussions of the numbers underlying the strategies. I hope that we can make preparations in the coming weeks for a proper testing and tracing strategy, proper border control to really take us towards the elimination goal when we're through these current restrictions. Again, do come back next week for the town hall. This video will be on the website in a day or two, and you can share it with others that you know who would like to know more about the numbers underlying the control strategies, and go back to it yourself, because there's so much information in there that it's very useful to be able to see it on replay. So thank you very much, all the audience as well, for your engagement and participation and questions, and hopefully see you next week on Monday. Thank you very much.